Hello everyone. So welcome to the recall session of Neet PG 2023 medicine questions. So before we start the discussion, let me tell you that overall it was a balanced paper with a mix of factual and clinical scenario based questions. So when you look at the distribution of the questions, you will also notice that many of the questions are interlinked to other subjects like pharmacology, pathology, microbiology. So a lot of integrated questions as well. Okay, right. So let's move forward and start discussing the questions. Moving to question number 1. The murmur pattern shown below is seen in. So they are asking you a question based on an image of a murmur pattern. So you can see the first heart sound, second heart sound, and the pattern of murmur is that of a pan-systolic murmur. You agree with me? So you can see that the murmur is starting from S1 and it extends throughout the duration of systole. So it is a pan-systolic murmur. Uniform intensity, you can even call it to be a holosystolic murmur. Okay, and the murmur is not extending to the diastole. So it is a pan-systolic murmur. So that is the information that I get from the image. Now let's have a look at the options: mitral regurgitation, aortic stenosis, pulmonary regurgitation, and tricuspid stenosis. Well, among the options, the only one with a pan-systolic murmur is that of a mitral regurgitation. So the MR or mitral regurgitation will be the answer. Let's just see the other options as well and the murmur patterns in those conditions. Well, I'm just showing you this table to make life a lot easier for you. The different murmurs: systolic murmurs, diastolic murmurs, and continuous murmurs. Okay. So when you look at these murmurs, the systolic murmurs can be divided into early systolic, mid systolic, late systolic, and pan-systolic. So pan-systolic, we just saw that it can be seen in mitral regurgitation and also in tricuspid regurgitation. Even in a ventricular septal defect also you can see a pan-systolic murmur, and the configuration will be, as I said, uniform intensity extending throughout the systole. Now, about early systolic murmurs, they can be seen in association with an acute severe MR and TR, which can occur in conditions like, say, infective endocarditis. An acutely developing MR can sometimes have an early systolic configuration, whereas chronic MR is pan-systolic. Even a small VSD also can have an early systolic murmur. Mid-systolic murmur is also known as ejection systolic murmur. So what are the conditions where you get ejection systolic murmur? You can see associated with high cardiac output states, aortic stenosis, pulmonic stenosis, HOCM, and ASD. So these are the conditions where you get the mid-systolic or ejection systolic murmur. The late systolic murmur is seen as in association with a mitral valve prolapse. So these are the systolic murmurs that you should be knowing about. Coming to the diastolic murmurs, early diastolic murmur is seen in aortic regurgitation and pulmonary regurgitation. And mid-diastolic murmur, often a hot favorite for your exams. So this can be seen in association with MS, mitral stenosis, tricuspid stenosis, the Carey-Coombs murmur, Austin-Flint murmur, and also associated with a severe MR, TR, VSD or a PD also, you may get a mid-diastolic murmur. Also in a left atrial and right atrial myxomas. Okay, so continuous murmurs, again important. It's again a previous question, causes of continuous murmurs. So PDA, coronary AV fistula, rupture of sinus of Valsalva, cervical venous hum, and also the mammary souffle of pregnancy. These are the causes of continuous murmur. Okay, so if you go back to the options, aortic stenosis is classically having a ejection systolic murmur. Okay, it is having a ejection systolic murmur. And the ejection systolic murmur of aortic stenosis, it has what sort of a character? Crescendo decrescendo. Okay, so it has a crescendo decrescendo nature. Crescendo decrescendo murmur. It's not uniform in intensity as well. Pulmonary regurgitation, we just saw that this is early diastolic murmur. Yes, this is early diastolic, and often has a decrescendo configuration. Okay, it has a decrescendo configuration. And tricuspid stenosis, we just saw that just like a mitral stenosis, it can produce a mid-diastolic murmur. Okay, it can produce a mid-diastolic murmur. Okay, right. So often, you get questions based on murmurs for your Neet PG exam. So in another exam, they might ask you about causes of ejection systolic murmur or a mid-diastolic murmur. So the table that I showed you, please be very thorough with that. Okay, right. So that's it about question number 1. Moving on to question number 2. So question number 2, it's regarding a 51-year-old female presenting with palpitations, chest discomfort and fatigue. So JVP is showing a prominent A wave and auscultation revealed a mid-diastolic murmur. What is the most likely cause? Options are mitral stenosis, tricuspid stenosis. Okay, then the third option was mitral regurgitation. Okay, I've written it as mitral stenosis again. So the third option was mitral regurgitation, and the last option was aortic stenosis. Okay, right. So what is the likely cause here? Again, see, look, let's have a look at the first line. Female presenting with palpitations, chest discomfort and fatigue. So it is a cardiovascular case, but again doesn't take us to the diagnosis there. It's a second line which gives us more clue. JVP showing a prominent A wave and auscultation revealing a mid-diastolic murmur. Now, in the previous question, we also saw the causes of mid-diastolic murmur. And we can see that from the options, both mitral stenosis and tricuspid stenosis can produce MDM. Obviously, mitral regurgitation is a pansystolic murmur and aortic stenosis is an ejection systolic murmur. So obviously, we have ruled out option C and option D. Okay. Now, what about option A and B? What is the answer? What do you think? See, just have a look at the JVP finding as well. The JVP is showing a prominent A wave. Okay. So when you compare mitral stenosis and tricuspid stenosis, just tell me which condition can produce a prominent A wave. It is the tricuspid stenosis. So please understand that tricuspid stenosis is likely to produce a prominent A wave in the JVP. So when you combine both the information, the correct answer is tricuspid stenosis. Okay, combining both the auscultatory finding and also the JVP finding. Okay, right. So I'm just briefing you on the A wave because it is often repeated in exams. So A wave, as all of you know, is produced by the right atrial contraction, which is a phenomenon that happens in the late phase of the ventricular diastole, and where there is an active atrial contraction. And when there is an atrial contraction, what will happen? Obviously, there will be back pressure to the jugular vein, and that is what produces this positive deflection A wave. Now, abnormalities of A wave, very important. Okay, abnormalities of A wave, very important. So, when you look at abnormalities, sometimes they have asked in the past about absent A wave. Very simple question. It is an atrial fibrillation because in AF there is no effective atrial contraction, correct? You have got fibrillating musculature, so there is no synchronized atrial contraction. Normally in you and me, we have got a synchronized atrial contraction, but such sort of a synchronized atrial contraction does not take place in atrial fibrillation, which is why you get absent A wave. Then coming to giant A waves, which can be seen in right ventricular hypertrophy and also tricuspid stenosis. So this is what we have in question on giant A waves seen in tricuspid stenosis. But let me also just tell you, even mitral stenosis, okay, even mitral stenosis, which is long-standing, can produce pulmonary hypertension. And you know that right ventricular hypertrophy often happens as a sequelae of pulmonary hypertension, correct? So even MS, long-standing, can produce pulmonary hypertension, then right ventricular hypertrophy, and subsequently you can get a elevated A wave, a prominent A wave. But when you look at the question here, see, there are no other findings suggestive of long-standing MS. They have not given any finding of pulmonary hypertension. So MS, it can, on long-standing, can produce a raised JVP, prominent A wave. But again, there are not much features suggestive of that. Okay, based on the available history, it is more likely to be a tricuspid stenosis, which can directly cause a giant A wave. Okay, right. Now, regarding Canon A wave, what is the difference between Canon A wave and giant A wave? Both are prominent A waves. The difference is, in case of Canon A waves, the right atrium is contracting against a closed tricuspid valve. And this can happen in case of complete heart block as well as junctional rhythm. In case of complete heart block, you can have an irregularly occurring Canon A waves. Okay, whereas in junctional rhythm, you get regularly occurring Canon A wave. Okay, so these are the abnormalities that you get in the JVP, A wave abnormalities. Okay, right. So that is clear. So the answer is going to be tricuspid stenosis. Moving to question number 3. Okay, question number 3. What is the aim of tissue plasminogen activator in the management of myocardial infarction? Okay, so this question is linked to pharmacology as well. So tissue plasminogen activator, so basically it is a fibrinolytic. Okay, it is a fibrinolytic, and you know that for the management of myocardial infarction and also stroke, in certain scenarios we use fibrinolytics. Okay, so we have got the recombinant tissue plasminogen activator, that is alteplase, yes, which is commonly used. And also you have got modified forms of the recombinant tissue plasminogen activator. One is tenecteplase, and also you have got reteplase. Okay, tenecteplase and also reteplase. Okay, now what is the aim here? Is it fibrinolysis, inhibiting platelet aggregation, inhibiting platelet adhesion, inhibiting thrombin? It's straightforward. It is going to be fibrinolysis. That is the answer. Okay, fibrinolysis. They are fibrinolytic agents. So if I take you to this simple flowchart in Harrison, see a tissue plasminogen activator. Okay, let's say alteplase or tenecteplase. Basically, what they'll be doing is they'll be converting plasminogen to plasmin. Okay, so they'll convert plasminogen to plasmin. And what does plasmin do? Plasmin is important for lysing the fibrin to fibrin degradation products. Okay, that's how it results in a fibrinolysis. Okay, fibrinolysis. You must also remember, in this fibrinolytic system, you've got certain, factors like plasminogen activator inhibitor. Okay, 1 and also alpha-2 antiplasmin. So these are certain checkpoints which will normally inhibit the endogenously occurring plasminogen activators. So in your body, the naturally occurring endogenous plasminogen activators are inhibited by these two substances. But you must understand that when you give a substance like reteplase or tenecteplase or alteplase, basically these are all plasminogen activators which will lead on to the formation of fibrin degradation products by lysing the fibrin. So basically, what is the utility of a fibrinolytic in myocardial infarction? It is to lyse the clot and it will help in revascularization. So whether it be a myocardial infarction, so in myocardial infarction, we know that in a ST elevation myocardial infarction, you will be using this tissue plasminogen activator, and also in the window period. Okay, and also in case of stroke, in the window period, you can use this The basic purpose is fibrinolysis and revascularization. Right. So that question is clear. Question number 3. Next, moving on to question number 4. A patient presented with retrosternal chest pain radiating to the interscapular area. Okay, and they have given that the patient is having a left arm BP of 180 on 100 and right arm of 120 on 90. The chest X-ray is showing a mediastinal widening. What is the diagnosis? So the first line is giving you some idea regarding the patient developing an acute onset chest pain. And the location is quite interesting. It is retrosternal, but it is radiating to the interscapular area. This is important. And the second line tells you that there is anisospygmia. Okay, where there is a BP difference between the both the upper limbs. And the chest X-ray is showing mediastinal widening. So what is the diagnosis? Aortic dissection, esophageal rupture, pulmonary embolism, foreign body in the trachea. So the options can actually produce chest pain. But see, a chest pain radiating to interscapular area. So chest pain radiating to interscapular area, a very severe tearing type of pain which can radiate to interscapular area can occur with aortic dissection. But sometimes even a myocardial infarction pain also can sometimes radiate to the interscapular area. But let us have a look at the second line. See, there is a BP difference in both the upper limbs. Now, this is unlikely to be associated with myocardial infarction. It is unlikely to be associated with pulmonary embolism, esophageal rupture, or a foreign body in the trachea. So, the second line essentially rules out the other options. And also the next line, chest X-ray showing mediastinal widening. You can say with more confidence that this is likely to be a aortic dissection, which is an acute aortic syndrome, a type of an acute aortic syndrome. So basically what happens in case of an aortic dissection is that there is a tear in the tunica intima. Okay, there is a tear in the tunica intima and blood actually gets into the vessel wall. There is a false lumen created inside the vessel wall due to the splitting of the media, and that is actually what is contributing to many of the manifestations. Okay, right. So some important points regarding aortic dissection. It is a tear in the tunica media, often facilitated by certain degenerative processes in the media as well. So whenever you have got certain degenerative processes in the media, tunica media, it makes the tear of the intima also easy and the dissection across the planes of the media also very easy. Now another potential MCQ is on the risk factors of aortic dissection. What are they? Number 1, connective tissue disease, bicuspid aortic valve, pregnancy and hypertension. So this is also a potential question. The characteristic pain in case of an aortic dissection is the sudden onset tearing or ripping type of pain. So this is often described with aortic dissection. Another point I want to tell you is a very unique point that can help you differentiate an aortic dissection pain from a myocardial infarction pain is, in case of myocardial infarction, when the patient develops an anginal chest pain, it is usually a crescendo type of pain. So patient starts to develop a chest pain and then it actually increases in a short span. But in case of aortic dissection, almost always right from the first second the patient develops the chest pain, it is a very severe chest pain. Okay, so the maximum intensity is often at the onset in case of an aortic dissection, whereas myocardial infarction usually has a crescendo type of pain. Okay, now regarding the location of the pain, well, it's not always that in aortic dissection you get a pain in the interscapular region. You must understand that the radiation of pain will also give you an idea regarding the direction of propagation of dissection. Especially the anterior ascending aortic dissections, they are likely to present with anterior chest pain, more towards the front. But it is the descending aortic dissections that are likely to produce a pain which radiates to the interscapular region. So you have got to keep that in mind. So for this question, it is mostly a straightforward question. Okay, so what about the other options? They have not put myocardial infarction to confuse you, but even if it was there, it should not cause much of a confusion, okay, except for the retrosternal pain that can occur there. But what about esophageal rupture? Even an esophageal rupture can also produce a chest pain, which can be retrosternal as well. But the point is, the clinical picture is not suggestive of a esophageal rupture, where the patient can present with number one, vomiting. So there is vomiting, there is chest pain, and there is subcutaneous emphysema. So this triad in case of an esophageal rupture is referred to as a Mackler's triad. Okay, is referred to as a Mackler's triad. So Mackler's triad is the characteristic triad in case of an esophageal rupture. So nothing suggestive of a Mackler's triad here. Now also about pulmonary embolism. Pulmonary embolism can have a chest pain, but not the typical description given in the question. Also unlikely to produce an anisospigmia, and also unlikely to have a chest x-ray showing a mediastinal widening. You know that there are other radiological findings in case of pulmonary embolism, like a Pella sign, okay, which is the enlarged right descending pulmonary artery. You can have the Westermarck sign, you can have the Hampton's hump, you can even have a dilated central pulmonary artery as well. So those are the radiological findings that you will attribute to a pulmonary embolism, and also foreign body in trachea is unlikely to again present with any sort of anisospigmia as well. Okay, right. So this question is also very clear. Let's go to question number 5. Okay, so question number 5 is regarding a middle-aged woman with bronchial asthma. Okay, so there is a background history of bronchial asthma and a history of thyroid disorder. So the patient has now presented with fever, tachycardia, and a high blood pressure of 180 on 110. ECG showed atrial fibrillation. What is the next step in management? Now this is slightly tricky, but a very simple question. See, first of all, let us appreciate that this patient is having a background history of bronchial asthma and a thyroid disorder. Now, in a patient with a pre-existing thyroid disorder, the patient is developing fever, tachycardia, and hypertension. What is that you will think of? Okay, especially in the setting of a hyperthyroidism, you will think of a thyrotoxic crisis or a thyroid storm. So this is where you have to apply your knowledge. This is likely to be a thyroid storm or a thyrotoxic crisis. So the clinical setting is that of a thyroid storm. And there is an atrial fibrillation seen on ECG. What is the next step in the management? Now, even after the exam, many students picked up this is a thyroid storm. But if you look at the options, esmolol, diltiazem, propranolol, propylthiouracil, I know that some of the students might have thought, okay, it is a thyroid storm. I've got it. The drug of choice, the antithyroid of choice will be propylthiouracil, and they saw that propylthiouracil is there in the option and they marked it. But let us try to just analyze the question once again. So you've got the patient with atrial fibrillation. Okay, atrial fibrillation. Okay. Now just tell me something. In a patient who has presented currently with a thyroid storm and an atrial fibrillation, what is your priority here? What is your priority? Your priority is to control the AF, because atrial fibrillation is something that can even kill the patient. It is a condition that can even kill the patient, and you want to manage the atrial fibrillation here. Yes, I'm not saying that managing the thyroid levels is not important. Yes, you've got to control that as well, but a top priority here will be the control of an atrial fibrillation. Okay, so the options esmolol, diltiazem, propranolol. If you see propranolol is not a cardioselective beta blocker, and especially in the context of a bronchial asthma, you're not supposed to give propranolol because it is likely to worsen it. So a propranolol will not be a choice. So what about esmolol and diltiazem? So esmolol is again a relatively cardioselective beta blocker, but even when I say cardioselective beta blocker, It just means that the beta 1 selectivity is more. It's not that it has zero beta 2 activity. There is some sort of a beta 2 activity as well, though it is predominantly cardioselective, and hence even esmolol is not my top priority here. Diltiazem, however, is a drug that can definitely be used in case of atrial fibrillation, and especially in this scenario of a patient having bronchial asthma, and this will be the answer. Whereas in case of propyl thiouracil, yes, propyl thiouracil can be given in this patient, but the immediate step, my priority, my number one priority will be to give diltiazem. Okay, the first priority is to give diltiazem and to control the atrial fibrillation. That is what is the priority here. Okay, now if you just have a look at Harrison as well. Okay, this is a screenshot from the Harrison's textbook of internal medicine. So you can see that in case of a thyrotoxic crisis or a thyroid storm, you look at this, the mortality rate due to cardiac failure arrhythmia can be as high as 30%. So when a patient presents with a cardiac arrhythmia, the mortality rate is very high. So you've got to address that immediately. So when the patient presents, you have to closely monitor the hemodynamic status of the patient, especially if the patient can go in for hypotension, and he can go on to develop a dangerous, all the arrhythmia can even predispose to a ventricular arrhythmia as well, because once all the signals comes to the ventricle, it can even predispose to a ventricular arrhythmia as well. So though I agree that propyl thiouracil is the anti-thyroid of choice, but again, for this case, the priority here will be, they have asked about what is the next step in the management. The next step will be giving diltiazem. Okay, I hope you have understood it clearly. Right, let's go to question number 6. Okay, question number 6, a patient was on treatment for hypertension, developed hyperkalemia. Okay, ECG is shown. Which drug can cause the side effect? So based on the recall what I got from the students, they said that already they had mentioned in the question, the patient had a hyperkalemia, and also the ECG was having hyperacute, in fact, tall peak T waves. So the ECG was showing evidence of tall peaked T waves. Okay, tall peak T waves. Again, once again substantiating that this patient is having ECG changes of hyperkalemia as well. They've asked about which drug can cause the side effect. Essentially, they are asking you which is the drug that can produce hyperkalemia. So when you look at the options, spironolactone, hydrochlorothiazide, metoprolol, and the answer here will be spironolactone. Okay, so spironolactone is the drug that can cause hyperkalemia. Drugs causing hyperkalemia is very important. If you look at this table as well, the medications causing hyperkalemia, you've got various agents like beta blockers, digoxin, AC inhibitors, ARBs, and potassium sparing diuretics. Okay, then the cyclosporin, heparin to a small extent, NSAIDs, and even succinylcholine, given the mechanism of hyperkalemia as well. But I think it's very important that you understand what are the medications that can lead on to hyperkalemia, because even in other clinical scenario based questions, they can slightly twist it and ask, maybe next time they can bring in a patient who is on digoxin, and so you can expect all those questions. Okay, so this one is quite straightforward. The answer is spironolactone, because it is a potassium sparing diuretic and it can cause hyperkalemia. Okay, right. Moving to question number 7. It's regarding a 50-year-old male who is a chronic smoker since 20 years. Okay. 3 days after stopping clonidine, he developed a pounding headache. What could be the correct explanation for the condition? So the first line is just telling you that he is a chronic smoker and he was on clonidine. Okay. And 3 days after stopping clonidine, he developed a headache. Okay, so why did the patient develop the headache? That is what they are asking you. The options are rebound hypertension, receptor hypersensitivity, postural hypotension, receptor upregulation. So it can never be a postural hypotension, because postural hypotension is a side effect that occurs in a patient who is on a clonidine therapy. It's not associated with stopping the drug. Now coming to the remaining options, rebound hypertension, receptor hypersensitivity, receptor upregulation. You must understand that in a patient who is on long-term clonidine therapy, when he stops the drug, there is always a chance of a rebound hypertension. So there is always a chance of rebound hypertension. And whenever there is a rebound hypertension, this patient can develop a headache. So in this question, what has happened to the patient is a rebound hypertension resulting in a headache. Now, if you look at the options, you see here there is receptor upregulation. In fact, a patient who was on long-term clonidine therapy, it's not upregulation that is there, it is downregulation. Okay, so patient on long-term clonidine, you will have a receptor downregulation only and not a receptor upregulation. Okay, so right, so the answer to this question is a rebound hypertension. Coming to question number 8, again a relatively factual question. I'm sure that this would have been discussed with the PSM recall as well. So when people were followed up from teen to adult, those with low BP remained low and the people with high BP remains high. What is this known as? So essentially they are telling that when you track individuals, maybe from their 30s and 40s to their 50s and 60s, you will see that patients who had a higher BP in the younger age group, the 20s, 30s and all, they would eventually go on to have a higher BP in the older age group as well. So this phenomenon is known as, can somebody tell me, this is known as a tracking of BP. This is known as a tracking of blood pressure. So I'm just showing you a figure as well. So tracking of blood pressure. So let's have a look at these 4 individuals. 1, 2, 3, 4. You can see that as time is progressing, time on the x-axis and BP on the y-axis. So one had a higher BP at a younger age, and as he went on to become old, you can see among the 4 individuals, he had the highest BP. A reverse is with candidate 4. You can see that he had the lowest BP, and when he was subsequently followed up, he ended up having the lowest BP. This may not be an absolute rule, but generally this is what happens. So this is known as a tracking of blood pressure. This is again a factual question. Okay, tracking of BP. Moving on to question number 9. So see, actually what was given is that a flowchart of the renin angiotensin aldosterone system was given, okay, in the actual question. And they had asked in the question, name the drug acting on 2 sites. So in that flowchart, one site was that of neutral endopeptidase, and the second one angiotensin converting enzyme. Okay, so these 2 sites were mentioned, and what is the drug that targets these 2 sites? Okay, is it sacubitril? Is it omeprazole? Is it losartan? Is it nesiritide? So basically, you must know about the group of drugs which are vasopeptidase inhibitors. And the classical example of a vasopeptidase inhibitor is omeprazole. So omeprazole is a vasopeptidase inhibitor. Okay, and basically they'll be inhibiting the neutral endopeptidase as well as the angiotensin converting enzyme. Subsequently, they'll cause vasodilatation, excretion of sodium, and they'll be having an anti-hypertrophic effect. So subsequently, it will help to lower the blood pressure, improve the cardiac performance. So there are multiple advantages to this drug omeprazole. So the answer here is omeprazole. The answer here is omeprazole, which is inhibiting both. Now coming to sacubitril. So you know about sacubitril-valsartan combination as well. This is also one previous question. So basically sacubitril-valsartan combination. So what does sacubitril do in this combination? It is that it inhibits the neprilysin. So this will target the neprilysin. It will inhibit neprilysin, whereas valsartan will be acting on the angiotensin receptors. Okay, receptors. So basically, what is this neprilysin? Neprilysin will actually help in the conversion of certain vasoactive peptides to inactive fragments. That is what neprilysin usually does. But when you give sacubitril, what happens is that this neprilysin is inhibited, resulting in the accumulation of these vasoactive peptides. So that results in vasodilatation and decreased activity of sympathetic and increased parasympathetic. Natriuresis decrease cardiac fibrosis and decreases the risk of arrhythmia. And similarly, as I told you, valsartan will block the angiotensin receptors as well. So that is the utility of this combination sacubitril valsartan. Okay, right. Now coming to the next option, nesiritide. So nesiritide is also a recombinant human B-type natriuretic peptide. So it is a recombinant brain natriuretic peptide. So this will also result in vasodilatation, which is again responsible for its pharmacological properties. So this is what you should know about the other options. Okay, so here the answer is omapatrilat. Okay, again a question that is integrating medicine with pharmacology, right? Okay, now next question, question number 10. A female patient who is a hypertensive presented with a sudden onset headache. The blood pressure is 160 on 100. CT is showing subarachnoid hemorrhage. What is the next step in management? So the comorbidity here is that of a hypertension, and the presenting feature is that of a sudden onset headache, and the patient is having a high BP at presentation. So we know that hypertension is one among the risk factors for a subarachnoid hemorrhage. We know that the most common cause is a trauma followed by a rupture of berry aneurysm. You also have got hypertension as a risk factor. So the patient is having a subarachnoid hemorrhage. The question is, what is the next step in the management? Now options are nimodipine, next is surgical intervention, third is esmolol, and fourth is angiography to find the site of aneurysm. So basically, when you have got a patient who is presenting to the emergency department, and suppose, you have taken a non-contrast CT brain, okay, non-contrast CT brain, and you see that this patient is having a subarachnoid hemorrhage. Now, what do you do here? Now, yes, you will give pharmacological measures as well. And you know that nimodipine is a cerebroselective calcium channel blocker. And the purpose of nimodipine in case of subarachnoid hemorrhage is not just to reduce the BP. Yes, you know that in case of subarachnoid hemorrhage, the guideline says that you've got to keep the target systolic BP less than 160 mmHg. So the target systolic BP should be less than 160 mmHg. Nimodipine will help in that. But more importantly, nimodipine will also help you in preventing a dangerous complication of subarachnoid hemorrhage, which is delayed cerebral ischemia. So delayed cerebral ischemia, which occurs due to vasospasm, is often an important complication of subarachnoid hemorrhage. No doubt about it. And for that, nimodipine has its utility. But my dear children, you should know that when you've got a patient presenting with SAH, yes, nimodipine is important. But see here, the patient has developed an SAH, correct? But is the SAH due to hypertension alone, or could it be due to rupture of a berry aneurysm? That is also important. The patient could very well have an aneurysm which would have ruptured. In that case, it is very important urgently to see if the patient is having any evidence of an aneurysm. Now, if you want to see if the patient is having an aneurysm, you should go for an angiography. You can go for a CT angiography, MR angiography, digital subtraction angiography. You've got to see the vessel and to see if there is any aneurysm. Why do you want to see if there is an aneurysm? See, the patient might be having two aneurysms, one of which would have ruptured. The other, since the patient is a hypertensive, might rupture immediately. So always remember, there is a chance of a rupture again. And because of which you have got to do the vessel imaging. And if there is any aneurysm, you have to deal with the aneurysm. Dealing with the aneurysm means there are two surgical options. Either you can put a coil inside the aneurysm, which is known as coiling, so that blood does not enter to the aneurysm. And also another procedure is known as clipping. So clipping and coiling are the surgical options that you have in hand. Okay. Now, see, let us look at the options here. So esmolol we know is not a part of the routine management of the subarachnoid hemorrhage, so we will rule it out. So what about angiography to find the site of aneurysm and then surgical intervention? So only if you do an angiography, you will know, is there an aneurysm? And if it is there, where is the aneurysm? So before doing an angiography, you will not proceed with the surgical intervention. So you will have to do the angiography first. Now between nimodipine and angiography, what is going to be the answer? Now this again is a question where you have to prioritize. Okay, both of them are a part of the management and both of them will be used in this patient. But they are asking about what is the next step in the management. So coming to the next step in the management, you must understand, see, giving nimodipine is going to prevent a delayed cerebral ischemia. But even that is not an immediate complication of SH. So it's not that which develops immediately. Okay. But what is the dangerous immediate complication is that of a rupture of the aneurysm. That is the immediate complication. If you look at the Harrison's textbook also, you will see that re-rupture in case of berry aneurysm is a feared event. This is in the chapter of the subarachnoid hemorrhage, and they have also written the risk of re-rupture is maximal in the first 2 to 12 hours. So it is the initial hours that the risk of re-rupture is maximal. Okay, which is why if you look again, Harrison, the treatment part for aneurysm, early aneurysm repair prevents re-rupture, and a definitive repair carried out within 24 hours of the bleed. Okay. So if the patient is hemodynamically stable, okay, if the patient is not hemodynamically stable and has collapsed and is very critical, you cannot take up obviously for a surgical procedure. But in patients who are stable enough to tolerate the procedure, they are advocating an early procedure within 24 hours, obviously because of the risk of a re-rupture. So because of which priority wise, you will have to go for angiography to find the site of aneurysm. That will be the better answer here. Okay. So again, I'm telling you, nimodipine is given, but again, they're asking you next step in the management. As a clinician, I have got to prioritize, and for that, option D will be the answer. Okay, right. Then question number 11. Right homonymous hemianopia, what is the site of lesion? I'm sure these are questions which will always give you a smile in any entrance exams because it is a relatively simple one. The site of lesions given are the left optic tract, left optic nerve, optic chiasma, and the right optic tract. So patient is having a right homonymous hemianopia. So we know that anything retrochiasmal is the one that is likely to produce a contralateral homonymous hemianopia. So in that case, it is very obvious the answer is going to be the left optic tract. And I think, you should know this figure also very thoroughly. So where I have listed down different sites, optic nerve, optic chiasma, then the optic tract, the optic radiations at different parts of the radiations. Okay. So, because even in the radiations, it can involve the lower fibers, upper fibers, or entire fibers, or you can have an occipital cortex lesion. So, if you look at site 3, which is the left optic tract, you can see that there is a right homonymous hemianopia. Okay, so that is very clear. But in case of site 1, where the optic nerve is involved, you get a monoocular blindness. Site 2, which is the optic chiasma, you get classically the bitemporal hemianopia. And the other sites, site 4 is where you get the lower fibers in the temporal lobe. So where you get a right superior homonymous quadrantinopia. And in case of site 5, wherein you have got the upper fibers of the anterior parietal lobe, you get a right inferior homonymous hemianopia. Whereas in occipital cortex lesion, what is the peculiarity? It's very important to know. Previous question as well. The hemianopia will be associated with macular sparing. And what is the reason for macular sparing in case of an occipital cortex involvement? It is because you know that there is a dual supply of the macular region by the MCA as well as PCA. So MCA and PCA. So even when the PCA is affected in an occipital cortex stroke, you have got some part of the MCA supplying the macula and you will get a macular sparing. Okay, right. So this is again a straightforward question, left optic tract. Okay, moving on to question number 12. A patient developed encephalitis. Okay, encephalitis and the CT brain showed bilateral temporal involvement with hemorrhagic areas. What is the causative agent? So they are making a statement that the patient has presented with encephalitis. Okay, so encephalitis can have varied etiologies, right? But what is going to clinch the diagnosis here is the imaging. So imaging is showing a bilateral temporal lobe involvement, and also you've got some hemorrhagic components to the involvement. So remember, HSV encephalitis, I've always told this, HSV encephalitis is always having a predilection to involve the temporal lobes. Commonly, they can involve bilateral temporal lobe, but mind you, it can even cause a unilateral temporal lobe involvement also. The next question they ask, they might give you a unilateral temporal lobe involvement. So that is also possible. So the answer here is HSV. Okay, HSV. So let me just show you one screenshot from Harrison. So about HSV encephalitis, you can see that almost 80% of patients with HSV encephalitis will have imaging abnormalities involving the temporal lobe, and this is usually seen in the medial temporal lobe first, and also it's not just restricted to temporal, even the frontal, especially the orbitofrontal region. Okay, especially the orbitofrontal regions, they can also be involved. Okay, now if you are asked in a question what is the most specific investigation, you can go for, nobody does a brain biopsy now. You can go for an HSV PCR. Okay, HSV PCR. Okay, so this is having a very high sensitivity and specificity. Okay, very high sensitivity and specificity. Okay, HSV PCR. Okay, right. So this is not a CT, this is an MRI, but just want to tell you that the temporal lobe as well as the frontal lobe are often favored. In this patient, bilateral temporal lobe, but mind you, even you can have a unilateral or a focal affection as well. Okay, and even when you do a CSF in case of HSV encephalitis, so in this patient, if you do a CSF, in addition to the cell count and protein, you can also see some RBCs. Okay, so you can notice some RBCs also on the CSF tap in patients with HSV encephalitis. So no doubt about it, but for your knowledge, let me also tell you tuberculosis, though it is not having a typical temporal lobe predilection, TB sometimes can have areas of hemorrhage, sometimes. But in case of, in medicine, it's always rarities are rare. Okay, so just because TB can rarely produce hemorrhagic areas, don't go for tuberculosis. So yeah, acanthamoeba can cause a meningoencephalitis, so can cryptococcosis, but none of them is having a temporal lobe predilection with hemorrhagic component. That's not a feature of any of the options. Okay, right. Moving on to the next question. Patient presented with pallor, UMN weakness of the lower limbs, absent ankle jerk, absent proprioception and vibration sense. What is the likely diagnosis? Okay, subacute combined degeneration, multiple sclerosis, amyotrophic lateral sclerosis, and Parkinson's disease. So patient is presenting with a range of manifestations. And one important manifestation is pallor. And along with that, he is also having an upper motor neuron type of weakness of his lower limbs with absent ankle jerk, absent proprioception and vibration sense. So, see, if you look at this, you've got hematological involvement here, correct? Hematological involvement because the patient is having pallor, most likely due to anemia. And weakness of lower limb. So there is neurological involvement, and it is a upper motor neuron that is getting involved. So there is a motor system involvement, okay, motor system involvement, and it is a UMN that is getting involved. But if it is only UMN, tell me, will there be an absent ankle jerk? No, you will have an exaggerated reflexes, right? Deep tendon reflexes will be usually exaggerated, but if it is absent ankle reflex, it suggests that there is some sort of an LMN involvement as well, okay? There is some sort of an LMN involvement. So absent proprioception and vibration tells me that the sensory system is involved, and the proprioception and vibration, these are carried by large fibers, okay, large fibers which go through the dorsal column. Now if you just analyze which is the condition that has got hematological involvement, motor system involving upper and lower motor neuron, and also the sensory system involving the large fibers. This is actually the manifestation of a subacute combined degeneration, okay? Subacute combined degeneration. So wherein the patient can have a B12 deficiency, correct? Vitamin B12 deficiency. So the vitamin B12 deficiency can lead on to anemia. Vitamin B12 deficiency can lead on to anemia. And there can be a posterolateral spinal cord involvement. So because of which there can be pyramidal features. So UMN weakness can occur. But remember, vitamin B12 deficiency can also involve the peripheral nerves. So it is because the patient has also got a peripheral neuropathy, he has got a absent ankle jerk. So there is an LMN involvement as well. And the dorsal column can also be involved, which is why there is absent proprioception and vibration sense. So this is how you have got to analyze and then come to a diagnosis of a subacute combined degeneration. What about multiple sclerosis? So multiple sclerosis, you're not going to get pallor. Okay, you're not going to get pallor. You can have upper motor neuron type of weakness. You can have the dorsal column involvement. But again, the LMN is not involved in case of multiple sclerosis. You're not going to get an absent ankle jerk. So that is not going to be the case. Amyotrophic lateral sclerosis, again, no pallor. And remember, it is a pure motor system disease. It is not going to produce any sensory manifestations. Parkinson's disease, you are thinking of an extra pyramidal involvement. You're not going to get a UMN type of weakness, not a pallor, no sensory, absent proprioception. These are not common features of Parkinson's disease as well. So again, answer is subacute combined degeneration. Right. Let's move to question number 14. So this is regarding a 70-year-old with recent history of dementia, visual hallucinations and staring at the sky. Autopsy showed Lewy bodies. What is the most likely diagnosis? Okay, now this is a very interesting question, and I've got to make some comments also on this question. Okay, so the options are Parkinson's disease, prion disease, Huntington disease, Alzheimer's disease. Okay, now this patient is presenting with dementia. Okay, visual hallucinations and some sort of a staring. Okay, maybe, the students say that it was given staring in the sky. So I'm just assuming that there was some sort of a staring and the blink rate was reduced. And autopsy shows Lewy body pathology. Okay, right. So there are limited Lewy body pathologies that you know. And one of them is Parkinson's disease. And the second one is Lewy body dementia. So the Lewy body diseases that you know, one is Parkinson's disease and the second one is a Lewy body dementia. Now out of these two, what do you think must be the answer? Obviously, you are not seeing a dementia with Lewy bodies, or DLB, I can say. Okay, LBD, I can even say dementia with Lewy bodies. So dementia with Lewy bodies, I am not seeing in the option. In fact, I asked many students also Wasn't there DLB in the option? They said, all of them said, sir, no, DLB was not there in the option. Because I was expecting that to be the answer. Because see, the patient is having a prominent dementia and visual hallucinations. Now, dementia and visual hallucinations are in fact very prominent manifestations of dementia with Lewy bodies. I was very surprised that that is not there in the options. Okay. Now, what else can be this? What else can be this? If you look, prion disease is not a disease where you get all these Lewy bodies. Okay. The history is not that of a rapidly progressive dementia. They have not given it. Okay. Huntington disease also not common to see the symptoms, as well as it's not a Lewy body disease. Alzheimer's disease is also not a Lewy body disease. So the only condition given in the options which is going to have Lewy bodies in autopsy will be Parkinson's disease. But let me tell you, I am very, very surprised at this question. This is not at all a common feature of Parkinson's disease. This is not how Parkinson's disease commonly presents. See, you must understand, they've said in the question that the patient is having dementia. Dementia is a late feature of Parkinson's disease. If you ask me, can dementia occur in Parkinson's disease? Yes, but very late. In fact, one of the prominent differences between Parkinson's disease and the dementia with Lewy bodies is, in Parkinson's disease, you will have many years of Parkinsonism and then development of dementia. In dementia with Lewy bodies, either you have got Parkinsonism and also the dementia occurring or more or less simultaneously, or within the first 1 or 2 years within the development of Parkinsonism, you will have dementia. Okay, early dementia is a feature. And visual hallucinations also is very, very rare in case of Parkinson's disease. Can occur, but it is very rare. So to be very honest, I still believe whoever has put this question was smoking some weed while putting this question, because I am not at all happy with the framing of the question. There is no element of doubt. It is an absurd question. There is no element of doubt. It is an absurd question. They should have put dementia with Lewy bodies, because see, I am a person who is commonly treating and seeing patients with DLB, Parkinson's. So we are commonly seeing these patients, and anybody who is routinely practicing knows how the patient is actually presenting. But unfortunately, I totally disagree to the framing of this question. But again, it's an entrance exam. So the only answer you can go for is, well, the basic rule is in an MCQ exam with 4 options. If 3 options are wrong, the 4th option has to be right. So that's the only logic I can pick up Parkinson's disease. Okay, right. Coming to question number 15. A lady noticed that her husband was being unable to express emotions. He also had tremors and slowness of gait. Where is the possible site of lesion? Okay, so unable to express emotions. So unable to express emotions, tremors and slowness of gait. So tremors and slowness of gait tells me that this is some condition where the extrapyramidal system is getting involved. So basically it's a basal ganglia disorder. Okay, so that is what I can understand. So unable to express emotions might be because of the hypomimia, where you get an expressionless facies. So you can have tremors, you can have slowness of gait associated with extrapyramidal disorders. So if you look at the options, cerebellum, basal ganglia, hippocampus, premotor cortex, well, straightforward. It's an extrapyramidal system involvement, basal ganglia involvement. See why both of them are equated, extrapyramidal system and basal ganglia? Because most of the extrapyramidal pathways will have a relay in basal ganglia. So which is why when you say extrapyramidal disorders, it's almost equal to saying that this is a basal ganglia involvement. Okay, so the answer here is option B, basal ganglia. Okay, all right, moving on to question number 16. A patient was admitted in the neurocritical care. The level of consciousness was assessed. His eyes were opening only to painful stimulus. And then on applying a painful stimulus, his limbs were withdrawing. Inappropriate words were being spoken. What is the GCS? So in any patient admitted to the neurocritical care, a very important tool in assessing the level of consciousness is the Glasgow Coma Scale, the GCS. Okay, right. So GCS is very important, often repeatedly asked in the entrance exam. So you've got to be very thorough with it. So GCS takes into account 3 parameters: the eye opening, the verbal response, and the best motor response. The minimum scores is 1 in each of the parameter. Maximum for eye opening is 4, verbal is 5, and motor is 6. Now, so the maximum score, total score will be 15 on 15, right? And the minimum score will be 3, okay? So even if someone is dead, you will still have a score of 3. So in a world full of competition, okay, it's strange that someone who is dead will still have a score with him. Okay, so that's it. See, when you look at this question, the patient, let's have a look at the eye response. Eyes were opening only to painful stimulus, so you will have to give it E2. Okay, and the verbal response, they said inappropriate words, and he was withdrawing limbs to painful stimulus, so M4. So E2, V3, M4 will be the answer. Option A, right? E2, V3, M4. Done? Okay. So that's it about question 16. Coming to question 17. So the patient had tingling and numbness in the lateral 3.5 digits. What is the diagnosis and choose the test? So basically it seems that in the options they had put the site of pathology and also the test to diagnose it. So why I've put this question in medicine is because it's a part of neurology, especially the element component, that is the peripheral nerve. It is basically a neuropathy that is being discussed here in this question. So the first statement tells you that the patient is having tingling and numbness in the lateral 3.5 digits, which is typically in a median nerve distribution, correct? Which is typically in a median nerve distribution. So median nerve distribution, where is the anatomical site of involvement? This is likely to be the carpal tunnel. Okay, because Guyon's canal, we know that it is the ulnar nerve that is getting involved. So I can straight away rule out option C and option D. So it is carpal tunnel, and you've got the Durkan's test as well as the Fromen's sign. So the common compressive neuropathy at the carpal tunnel is the carpal tunnel syndrome, which is CTS, which occurs due to compression of the median nerve at the carpal tunnel. And so diagnosis is carpal tunnel syndrome, no doubt about it. And the test to diagnose, see, there are certain provocative tests to diagnose CTS. Yes, the patient will be coming to you and telling you that there are sensory symptoms, a tingling, numbness in the 3.5 digits. But if you just want to have a test that will provocate these symptoms, there are a few important tests. One is the Durkan's test, and in fact, Durkan is a very good test. And Durkan's test is basically direct compression of the median nerve. Okay, so basically what is done in the Durkan's test is that at the wrist, you are directly compressing the median nerve for around 30 seconds. So when you compress the median nerve for 30 seconds, the patient develops these symptoms. So the patient is in front of you, you're doing the Durkan's test, the patient develops these symptoms, and he tells you, doctor, this is exactly what I am having, you know, as a problem. Okay, so it's a provocative test, it's Durkan's test. And there are other provocative tests. One is Fallon's test. Fallon's test, again, you can see that the arms are raised to the shoulder level and the dorsum of the hands are actually brought in the midline, and you're keeping in this particular posture for around 30 to 60 seconds. Again, this is also a provocative test which will compress the median nerve, and the patient will be getting the sensory symptoms over the median nerve distribution. Another test is a tapping or a percussion over the median nerve, which will produce the similar symptoms, which is called the Tinel's test. So all these symptoms, the Fallon's maneuver, reverse Fallon's, the Durkan's test, the Tinel's test, all these are provocative maneuvers for carpal tunnel syndrome. So the answer here is obvious. It is Durkheim's test. Fromen's test is actually for the ulnar nerve. Fromen's sign is for ulnar nerve, the book test that you actually do. So it is basically testing for the adductor pollicis, which is supplied by the deep branch of the ulnar nerve. So here, no doubt, the answer is option A. Okay, right. Moving on to question number 18. So, 50-year-old patient with history of trauma 1 week back before, he came with confusion and ataxia. So, taking treatment for alcohol dependence, and his last intake was 2 weeks back. Okay, CT scan image is shown. So, he is actually an alcoholic with a history of trauma 1 week back. And he's having some neurological symptoms in the form of confusion and ataxia. And you can see that he has been taking alcohol and his last intake was 2 weeks back, and the CT is being shown. Now, CT, if you look at the image, you are seeing the typical crescent shape. So you are seeing hyperdensity, which is suggestive of a bleed. And the shape like a crescent is suggestive of a subdural hemorrhage, okay, SDH. And also remember, in case of EDH, it will be a biconvex. So EDH usually has a biconvex shape of the bleed. SDH is a crescent shape. Subarachnoid hemorrhage, you will have bleed extending into the fissures. And definitely this is not, this is, when you say intracranial, it's just a term for everything together, SDH, EDH, SAH, and even the intracerebral hemorrhage, all of them together, the term is intracranial hemorrhage. So here when I look, it is going to be an SDH. Okay, and there is one more clinical pointer here in this question. See, if you see, the patient had a trauma of 1 week before. So it took 1 week to develop these symptoms. Now this is more common in EDH or SDH, a relatively subacute presentation. It's more common in SDH. Can you tell me why? Because in case of EDH, most commonly it occurs due to the rupture of middle meningeal artery. Correct or not? So EDH, most commonly it is due to the rupture of middle meningeal artery. Whereas SDH is most commonly due to the rupture of the bridging veins. It is due to the rupture of the bridging veins. Okay, so one is an arterial bleed, one is a venous bleed, which is a high pressure bleed. Obviously, the arterial blood is a high pressure. So since the venous bleed is slightly at a lower pressure, sometimes SDH might take some time for the symptoms to develop. And that is also one point that is suggesting that this is SDH. And also remember, SDH, unlike EDH, will definitely cross the suture lines. So that also is a point that you have to take into account. Okay, right. Moving on to question number 19. A young man with a history of physical fight presented in the emergency with pain in the neck. Imaging revealed penetration of bony fragment to the lateral aspect of the dorsal column of the spinal cord. Which of the following will be affected? Is it proprioception in ipsilateral arm, proprioception in contralateral arm, weakness involving fine movements of distal muscles in ipsilateral arm, and proprioception in the ipsilateral leg? So basically, it's a history of trauma, and after that there is a spinal cord injury. So basically they are trying to test your knowledge on the spinal cord anatomy. Again, an integrated question here. So if you see here, the patient is having a pain in the neck. So the trauma was in the neck, and imaging is revealing a bony fragment in the lateral aspect of the dorsal column. Okay. So indirectly they are asking you which is the anatomical structure there. Okay. Or the lamination. If you see this picture from Harrison on the various structures in the spinal cord, if you of this crowded figure, just focus only on the dorsal column. If you look at the lamination, you can see the sacral fibers are most medial and the cervical is most lateral. So if in the dorsal column, if there is a bony fragment in the lateral aspect of the dorsal column, if there is a lateral aspect of the dorsal column is involved, obviously it is the cervical fibers which are likely to be affected. Okay, and you also very well know that the dorsal column does not cross at the level of spinal cord. So whatever fibers are traveling through the cord in the posterior column, they would have carried the sensations from the same side limb. So you will have, since the cervical is involved, the proprioception loss, okay, will be there in the ipsilateral arm. So it is an ipsilateral arm proprioception which will be affected. Basic question, right? Okay. So you've got to be very thorough with the anatomy. Only then you can all these questions with confidence. Okay. Coming to question number 20. 40-year-old patient with chronic alcohol abuse presents with confusion and ataxia. On examination, there was nystagmus and sixth nerve palsy. What is the likely diagnosis? So, alcohol-related disorders. Okay, alcohol is the national drink of our country. So, there has to be a question related to alcohol in every exam that you write. So, the patient is having neurological manifestations in the form of confusion and ataxia. Okay, and positive examination findings, nystagmus and sixth nerve palsy. So chronic alcoholic abuse, background history, confusion, nystagmus, ataxia, sixth nerve palsy, clearly heading to the presentation of Wernicke's encephalopathy. Remember, even Korsakoff syndrome is a related syndrome, but there is no definite mention of any memory loss or confabulation. So I'm not picking that as an answer. But remember, basically Wernicke encephalopathy and Korsakoff syndrome is a part of the same spectrum. Okay, so one side you have Wernicke's, and as it progresses after recurrent attacks of Wernicke's encephalopathy, patient goes into a state of Korsakoff syndrome or a Korsakoff psychosis. What about delirium tremens? Delirium tremens is mostly a withdrawal manifestation. So they have not mentioned about stoppage of any alcohol. So this usually happens 48 to 72 hours after stopping alcohol. And often the patient will have symptoms like tremors, important, hallucinations and seizures. This is also an expected question. Maybe in the exam that you are writing up next, they might ask you about the delirium tremens. So, but again, no such features suggestive of a delirium tremens. What about Miller-Fisher syndrome? See, Miller-Fisher syndrome also can have ataxia. There can be nystagmus. But remember, the patient with the Miller-Fisher syndrome, which is a variant of GBS, can have ophthalmoplegia, can have nystagmus, can have ataxia. But it is unlikely and very rare for a patient to present with neurologic symptoms like confusion, and also they need not make a specific mention of a chronic alcohol abuse as well. Okay, right. So that point is also clear for you. Okay. Moving to question number 21. A patient with refractory hyperkalemia is treated with hemodialysis, but the dialysis is leading to headache and seizures, and he is being diagnosed as a dialysis disequilibrium syndrome. How will you treat this patient? So remember, a patient is being taken up for dialysis, the indication being a refractory hyperkalemia. Most likely it might be a chronic kidney disease patient with a refractory hyperkalemia, not responding to the medical management. And they have listed an important complication that can result in patients doing dialysis often for the first time. So when you do dialysis for the first time often, and when you have a significant elevation of the the blood urea, so what can happen is this can lead on to a state known as a dialysis disequilibrium. Okay, so usually patients who are taking dialysis for the first time, can sometimes also happen in patients who are on routine dialysis when they skip some dialysis sessions, and obviously because of that the blood urea creatinine is very high, and so that there is a significant concentration gradient between the blood of the patient and the dialysate fluid. The blood of the patient will be having so much of these nitrogenous waste products compared to the dialysate fluid. So much of shift will actually happen. So this can result in increased in the intracranial tension. So there can be a rise in the intracranial tension, and this is what you call as dialysis disequilibrium syndrome, wherein the patient can present with headache and seizures. So they are basically asking you about the treatment of dialysis disequilibrium syndrome. So basically it is increased intracranial tension, Even if you apply your common logic, you know that raised ICT, you will go for mannitol. Another option that you can go for is a hypertonic saline, that is 3% saline also is an option. So that will be given in this patient. Okay, so mannitol is the answer for this question. Coming to the next question, 22. 23-year-old medical student presents with palpitation, sweating and tremor. What investigation should be done next? They had shown an image of exophthalmos as well. So that is what the students told me in the recall. Exophthalmos image also was there. So it's quite straightforward that in this patient presenting with palpitation, sweating, tremor and exophthalmos, you are possibly considering Graves' disease. Okay, you're possibly considering a hyperthyroid state. Commonly in this age group, you may get a Graves' disease. So what investigation should be done next? Anti-TPU antibody, anti-TSH receptor, anti-thyroglobulin, anti-GAD. So remember that, you can have anti-TPU, anti-TSH receptor, anti-thyroglobulin all being associated with Graves to different extents. But the most specific one and the most important one in the evaluation of Graves' disease is an increase in the anti-TSH receptor. So these are thyroid stimulating immunoglobulins. So that is the antibody. But to a small extent, you can also have anti-TPU as well as anti-thyroglobulin. But the best answer, the most specific, will be the anti-TSH receptor. Okay, right. Next question, a patient with a lung mass has hypercalcemia. What is the likely cause? So, squamous cell cancer, small cell carcinoma, adenocarcinoma, large cell carcinoma. So, malignancy associated with hypercalcemia, how does that happen? Paraneoplastic syndrome. So, when you consider lung malignancy and paraneoplastic syndrome, mostly it goes hand in hand with small cell carcinoma. Majority of the paraneoplastic manifestations of lung cancer, it is associated with small cell carcinoma, but hypercalcemia is an exception. Hypercalcemia is most often associated with a squamous cell cancer. I'll just show you this table from the Robbins textbook of pathology. It's actually a very big table on the various paraneoplastic manifestations. I'm just focusing on the one part alone, that is the endocrinopathies part alone. So you can have Cushing syndrome, you can see small cell lung cancer, syndrome of inappropriate ADH secretion, also lung cancer. There are certain other malignancies also, but I just want to tell you that lung cancer, small cell is associated with Cushing and SIADH. But coming to our question is on hypercalcemia, which is most commonly associated with squamous cell variant of lung cancer. Okay, I think it's also useful to go through the other paraneoplastic manifestations as well and the associated malignancies, because there might be a future question from that. Okay, for this question, it's straightforward. It is a squamous cell carcinoma. Okay, right. Moving on to question number 24. 50-year-old man who is a chronic smoker presents with pain in the right arm. Okay, there is also evidence of ptosis. Chest X-ray is given below. The history is telling you that it is a chronic smoker, and pain in the right arm is the manifestation, and also there is evidence of ptosis. X-ray is showing that there is so if you look at the chest X-ray of the patient, so you can see that there is a homogeneous opacity in the apex of the lung. Okay, you're seeing that? Yes. So in this patient on the right side, you're having the mass there. So what is this likely to be? See, pain in the right arm, ptosis might be a part of the Horner syndrome. So this is likely to be a Pancoast tumor. Okay, this is likely to be a Pancoast tumor. Why? Because see, when you have got these Pancoast tumors, which are apical lung tumors, they're also referred to as superior sulcus tumors. So if you look at the anatomy here of the Pancoast tumor in the lung apex, they can compress on the local anatomical structures. One is the brachial plexus, especially the CA-T1 region, and also you have got the sympathetic trunk as well. So this can be involved. So when the CA-T1 is getting involved, you will have pain along the ulnar border of the upper limb. And also, since the sympathetic chain is involved, the patient can have features of Horner syndrome, wherein he can have manifestations of ptosis, he can have meiosis, he can have anhidrosis. Okay, so ptosis, meiosis, anhidrosis. So all these manifestations can occur, and even the loss of ciliospinal reflex as well. All these manifestations that can occur in case of patients with the Horner syndrome. Okay, so this is often a result of Pancoast. Okay, so the diagnosis here is that of a Pancoast tumor. Pulmonary aspergilloma patients, aspergilloma, in a cavity you get the fungal involvement. Is usually presenting with hemoptysis. I'm not seeing any hemoptysis, and the other manifestations are unlikely. Upper lobe pneumonia, again, Horner syndrome is not going hand in hand. So is the pain in the right arm. SVC obstruction, you will get more features of congestive features involving your face and raised non-pulsatile JVP. None of them you are seeing in the options in the question. So the answer here is straightforward, Pancoast tumor. Okay, right. Question number 25, a patient presented with fatigue, gum bleeds, and also with features of DIC. The peripheral smear shows blast with the following finding. They had shown an image. What is a likely genetic aberration? So fatigue, gum bleeds, and also features of DIC, we are thinking of a hematological problem. So they have said that peripheral smears are showing blast, so we are thinking of a leukemia. And you can see what is the finding here, the presence of multiple ORRODs. So when you get multiple ORRODs, promyelocytes containing multiple ORRODs, these are known as Faggot cells. Okay, these are known as Faggot cells. So which is most commonly, so these ORRODs are most commonly associated with AML-M3. So what is a translocation associated with AML-M3 or acute promyelocytic leukemia? It is translocation 1570. Okay, that is the translocation associated. So answer is option A. The likely genetic aberration in this case is, translocation 1570. Okay. Moving on to question number 26. A 10-year-old patient recently underwent a pituitary surgery, following which his urine osmolality is 100 milliosmol per kg and serum sodium is 154 milliequivalents per liter. And they are asking about what is the diagnosis and the management. So if you look at the options, each option has got two parts, one for the diagnosis and the other for the management. So option A, diabetes insipidus and give desmopressin for 2 weeks. Option B, diabetes insipidus, give desmopressin permanently. Option C, dysregulation of osmoreceptors being the diagnosis and that no treatment is required. I could not get what is the fourth options from the student record. Now let's try to analyze this question. So the patient recently underwent a pituitary surgery. Okay. Following which you can see that there is a decrease in the urine osmolality, correct, 100 milliosmol, and there is an increase in the serum sodium. There is hypernatremia, okay, hypernatremia. Now, what do you think is the diagnosis here? See, diabetes insipidus is one of the complications that can develop following a pituitary surgery. So, in this patient with a background history of a pituitary surgery, following which you are having a low urine osmolality and a hypernatremia, I'm thinking of diabetes insipidus as the diagnosis here. Okay, so there is no doubt on that. Now, for the management part, you know that the synthetic analog of arginine vasopressin, which is the desmopressin, is used in the treatment. So, desmopressin is used for the treatment of diabetes insipidus. But the question is, should the desmopressin in this case be given for 2 weeks or the desmopressin be given permanently? Okay, for this you have got to have a good idea about this topic. See, please understand that following a pituitary surgery, the diabetes insipidus that develops is often, in most cases, a transient one. Okay, a transient one. Only very rarely is there a possibility of a permanent diabetes insipidus. It's usually a transient one. Okay, so since it is more commonly a transient one, we commonly go for a shorter course of desmopressin. Okay, so though there is no definite guideline saying that, okay, you give for 2 weeks only, but generally only a short course treatment is required with desmopressin, because of which the answer is going to be option A. It is a case of diabetes insipidus and you give desmopressin for around 2 weeks. Okay, clear. Moving on to question number 27. Again, a question which integrates medicine with pharmacology. It's regarding an elderly male patient with a prior history of myocardial infarction and ventricular tachyarrhythmia. Is being treated for the last 4 years with medications. He is having dry cough and dyspnea fatigue for the last 3 to 4 months, and is diagnosed to have pulmonary fibrosis and also developed new onset hypothyroidism. What drug is responsible? Is it amiodarone, atorvastatin, spironolactone, or metoprolol? So the background history is that of prior myocardial infarction and tachyarrhythmia, because of which he was on certain medications. And now what is his problem? He is having dry cough, dyspnea and fatigue for the last 3 to 4 months. He was evaluated and was diagnosed to have pulmonary fibrosis, and also there is a new onset hypothyroidism. So out of the multiple medications that he must have been on, what is a drug that is likely to be responsible? So what is the answer here? This list of side effects which are given here is that of amiodarone. So amiodarone is the answer here. So when you look at the toxicity due to amiodarone, so this is a screenshot that I have taken from the Katzung's textbook of pharmacology. So what are the important toxicities, side effects of amiodarone? So dose-related pulmonary toxicity is the most important side effect. So you can have pulmonary fibrosis. Okay, so pulmonary fibrosis is an important side effect. You can also have abnormal liver function test. You can also have photodermatitis and a gray-blue skin discoloration in the sun-exposed areas, which is also a previous question that was asked. Asymptomatic corneal microdeposits can occur, okay, which are seen in many patients being treated on amiodarone. Okay, and then amiodarone can also result in thyroid problems, either hypothyroidism or hyperthyroidism. It can block the peripheral conversion of thyroxine T4 to T3 as well. So the ones that I have highlighted in green are the ones they have picked up for this question: pulmonary fibrosis and hypothyroidism. So the answer to this question is amiodarone. Okay, right. Moving on to question number 28. Again, this is again a question which is integrating medicine with radiology. 35-year-old patient presented with cough and fever for the last 10 days. Okay, there are crepitations on the right side of the chest X-ray is done. What is the diagnosis? Now, let's just forget about the X-ray for just a few minutes. You look at the history. Last 10 days, patient is having fever and cough. Okay, crepitations on auscultation, you're thinking of a pneumonia here, correct? The clinical picture is that of a pneumonia. Now, the X-ray, what is it showing? You're seeing consolidation, middle lobe consolidation, apical segment of lower lobe consolidation, posterior segment of lower lobe consolidation, and a loculated pleural effusion. So if you look at the X-ray of the patient here, so you are seeing some opacities, okay, non-homogeneous opacities in the lower lung fields. And see, the point here is they are asking which part is the consolidation. Okay, now the interesting point here is, just tell me, looking at the X-ray, can you very well delineate the right heart border? Yes or no? Can you very well delineate the right heart border? No, you cannot exactly delineate the right heart border. Why? Because this opacity that you are seeing here is involving the right middle lobe. Okay, so the middle lobe is being involved, and since the middle lobe is abutting the right heart border, it is obscuring the outline of the right heart border. Okay, and what do you call this sign? This sign is known as Sillaud sign. Okay, this sign is known as Sillaud sign. Okay, Silhouette sign. So what exactly is the Silhouette sign? Silhouette sign means, when you have got two opacities of the same density in contact with each other, their respective contours will disappear, as you see here. Okay, so there is an opacity, same density. So that is what happens when you have got opacity just in the middle lobe, just adjacent to the heart. They'll obscure the heart borders as well, the right heart border. Okay, so essentially, it's though the term is a Silhouette sign, the actual terminology should have been a loss of Silhouette sign or a loss of outline. Okay, that is actually a misnomer, is this sign, Silhouette sign. Okay, so there is actually a loss of the outline that is happening in this condition. On the other hand, when you have got two opacities which are separated by a tissue of a different opacity, in this case that you are seeing, there is air surrounding it. So though you can see there are two opacities, but they are separated by a tissue of a different opacity like the air. So then their respective contours will be visible, as in this case. Okay, so this is a Silhouette sign, the loss of the outline of the right heart border. This is associated with a right middle lobe consolidation. Okay, right. Coming to question number 29. Person working in cement factory for 20 years, okay, developed mesothelioma. What is the likely diagnosis? So there is a occupational history given, and it's a long-term exposure. Patient has developed mesothelioma. Is it asbestosis, bichinosis, anthracosis, silicosis? It's a straightforward question. Answer is asbestosis. So you must understand that asbestosis can have varied pulmonary manifestations, like, which are they? You've got the pleural plaques, okay, you've got pleural effusion, diffuse interstitial fibrosis, carcinoma lung, and the final one, mesothelioma. Mesothelioma is one of the manifestations that can develop in patients having asbestos exposure for a long time. Okay, so the answer here is asbestosis. But if you have look at this table in Harrison on the various occupational exposures and the associated diseases, so asbestos exposure, you can get it in those working in the cement factory, but even those working in the mining factory, processing factory, construction, ship repair, they are all prone to develop asbestosis. Patients may develop, as I said, fibrosis, pleural disease, malignancies, mesothelioma. Silica exposure is related to silicosis, which is again a fibrosing disease. You can have progressive massive fibrosis, malignancy. It increases the risk of tuberculosis, and you can even have obstructive pulmonary disease as well. Coal dust exposure can cause anthracosis. So coal workers, pneumoconiosis, progressive massive fibrosis, and again you can have an obstructive lung disease. Beryllium exposure can result in either an acute pneumonitis or a chronic granulomatous disease. And a very important differential diagnosis of the chronic granulomatous disease due to beryllium is sarcoidosis. So it's an important differential, sarcoidosis. And cotton dust can result in bichinosis. Okay, so wherein you can have asthmatic episodes or chronic bronchitis, or sometimes even a obstructive lung disease as well. Okay, so just keep in mind these points as well, because see, topics are often repeated. They may not ask you the exact question, but next time they may ask you a question on silicosis, berylosis, or bichinosis. Okay, so in this question, it's a clear-cut question. The answer is asbestosis. Okay, right. Question number 30. There cannot be any NEET PG question without a question on hepatitis B, is what I always tell my students. So this is a patient with hepatitis B and a high viral load. HBsAg was positive, HBAg was positive, and they were asking about what is the treatment of the patient. Is it interferon alpha plus lamivudine, or lamivudine only, interferon alpha only, or is it tenofovir? So coming to the drugs that are available for the treatment of hepatitis B, you have got the nucleoside and nucleotide analogs, out of which you have got the entecavir and then tenofovir. There are two preparations which are commonly used. One is alafenamide and the other is disoproxil. So out of these two preparations of tenofovir, the tenofovir alafenamide is the one which is better, or you can say having a better potency as well. So it's more favored. And then you've got lamivudine, adifovir and telbivudine. But out of all these drugs, the first two, entecavir and tenofovir, these are the ones which are more preferred, especially the alafenamide preparation, which is TAF. Okay, the short form is TAF. So these are the ones commonly used. Lamivudine has a problem with certain mutations. That is, you have got the YMDD mutations as well. So that's why the first two are preferred because of higher potency and lesser risk of resistance. Okay, lesser risk of resistance. Okay, right. Previously, we used to give all this interferon alpha and pegylated interferon alpha, which is not much preferred nowadays because of the various side effects associated with these preparations and also the continuous need to take injections. So in this case, the answer is tenofovir. Okay, tenofovir. Okay, tenofovir. Right. Moving on to question number 31. A chronic alcoholic presents with loss of weight. Serum alkaline phosphatase was more than twice the normal, elevated. AFP also was elevated. AST and ALT were normal. What is the probable diagnosis? So it's again straightforward. You have got a patient who is a chronic alcoholic. Okay, chronic alcoholic. What is the presenting symptom? Loss of weight. Okay, any patient with loss of weight, you've got to think of some catabolic disease like a malignancy here. So ALP is elevated, doesn't give you much idea regarding the exact cause, but you can see that the tumor marker alpha fetoprotein is elevated. So the answer is going to be hepatocellular carcinoma. HCC is the answer. Okay, right. Please also go through this table from Harrison wherein they have listed the various tumor markers and associated malignancies. You can expect future questions also from this. HCC, human chorionic gonadotropin associated with gestational trophoblastic tumors and gonadal germ cell tumors. Calcitonin with medullary carcinoma thyroid. Catecholamines with pheochromocytoma. Alpha fetoprotein, I just told you, hepatocellular carcinoma. Carcinoembryonic antigen CEA with malignancies of the colon, pancreas, lung, breast and ovary. Then the prostatic acid phosphatase with prostate cancer, neuron-specific enolase with small cell lung cancer and neuroblastoma, LDH commonly elevated in lymphoma, may be elevated in Ewing sarcoma as well, prostate-specific antigen, prostate cancer, then you have got myeloma where you can have monoclonal gammopathies, CA125 especially in ovarian cancer, CA19-9 colon and pancreas, CD30 Hodgkin's and anaplastic large cell lymphoma, CD25 hairy cell leukemia and adult T cell leukemia lymphoma. So just go through these. Even certain non-neoplastic conditions may also be associated with certain tumor markers. Okay, right. Most importantly, I've got to remember all the malignancies associated. Okay. Coming to next question, question number 32. Patient who is having hepatitis B had elevated serum creatinine. Okay. Spike and dome pattern was seen on renal biopsy. What is the diagnosis? So background of a hepatitis B. Okay, patient is now having an elevated serum creatinine. Okay, and there is a peculiar renal biopsy finding that is shown is the spike and dome pattern, which is the clinching point here. Okay, so the answer here is membranous nephropathy. Okay, membranous nephropathy or a membranous glomerulonephritis. So I'll just tell you what you have got to know here. See, in case of a membranous nephropathy, when the immune complex deposits occur, I've taken this picture from Robbins. So you have got these subepithelial deposits and you can see that they are very adjacent to the basement membrane. And can you see that between the immune complex deposits, there are spiky projections. Okay, spiky projections of the basement membrane. Okay, so there can be certain spikes, and sometimes what can happen is the spike can fully cover the immune complex deposits and can actually, bury the immune complex deposits. Okay, so this appearance is known as the spike and dome pattern, and you can even see in Robbins this being mentioned. So this is the morphology in case of a membranous glomerulonephritis. So the basement membrane material is laid down between the immune complex deposits, appearing as irregular spikes protruding from the base membrane, and the spikes can thicken to form dome-like protrusions which will eventually close the immune deposits. Okay, what about the relation with hepatitis B? Well, when you look at the causes of membranous glomerulonephritis, I've taken this from Harrison. You can see that I've already mentioned in my lectures as well there is an association with infections like hepatitis B. But mind you, this is not the only renal condition associated with hepatitis B. You can have other glomerulopathies as well. But again, there is an association with hepatitis B in case of membranous glomerulonephritis. Question number 33. A patient had a history of pyoderma 2 weeks back, and patient had cola-colored urine and serum creatinine of 2.3 milligram percentage. 3 weeks later, the creatinine now is 4.6. On biopsy, the light microscopy will show. Is it subepithelial deposits? Is it crescents? Is it subendothelial deposit? Or is it normal finding? So let's try to analyze this case. So there is a history of an infection, background infection 2 weeks back. Okay. What is the current presentation? With cola-colored urine and a creatinine of 2.3. So there is an acute kidney injury, and this most likely is due to a glomerular cause, and I can say that this is a nephritic presentation. Okay, nephritic presentation, or I can say that is a glomerulonephritis. But you can see the point here is in 3 weeks, you see now the creatinine is 4.6. So there is a significant worsening over a period of 3 weeks. And what is going to be the finding in microscopy? So the diagnosis here is that of an infection-related glomerulonephritis. So post-streptococcal glomerulonephritis is the diagnosis. PSGN is the diagnosis. Now the diagnosis is PSGN, clear. But is there something more to it? See, you can see that the creatinine is rapidly deteriorating here. Okay, so I can say that this is a rapidly progressive renal failure. In this case, since it is a glomerulonephritis, I am giving this term RPGN. So commonly, which is the condition that you know associated with RPGN, Goodpasture syndrome. Is commonly PSGN going to lead to RPGN? No. But rarely, PSGN can also result in a rapidly progressive glomerulonephritis. So the scenario here is that of a rapidly progressive glomerulonephritis. Okay. Now they're asking, what will the light microscopy show? See, in this case of a rapidly progressive glomerulonephritis, one of the unique points that you will see in the light microscopy will be the presence of crescents. I've stressed in my lectures also importance of crescents, suggestive of an aggressive and rapidly progressive disease. So you see this when you get a glomerulonephritis. In many conditions you get hypercellularity. Okay, and you can see that in Robbins they are mentioning about formation of crescents, mostly associated with an aggressive clinical picture where you get proliferating cells in the parietal epithelium. So there is proliferating glomerular epithelial cells and infiltrating leukocytes, which are known as crescents. I'll just show you an image, almost a similar image that I have shown in my lectures. So you can see that there is a significant proliferation here. Yes, you're noticing. So this is the proliferation in a crescent shaped manner. Can you see the crescent shaped manner where you have got all this proliferation? Yes. Okay. So this proliferation is there, and this is actually a crescent. So in light microscopy, the finding will be the presence of crescents. But some students, when I discussed with them, they said that the question was not asking about light microscopy. It was specifically mentioned that it is an electron microscopy. Okay, electron microscopy. So some students told me the question they asked about electron microscopy. Now let us assume the question was electron microscopy. In that case, crescents is something that you appreciate in light microscopy and not electron microscopy. So if that was the question, then the answer will be subepithelial deposits. Okay, you're seeing subepithelial deposits. Okay, so the answer will depend upon what exactly is asked, but I hope the idea has been conveyed to you so that, in whatever way the question is asked to you, you can write it. But did you understand that I had to pick up a scenario of a RPGN here? Because it's not just any PSGN, it is a rapidly progressive glomerulonephritis here. Okay, right. Moving on to question number 34. An alcoholic male presented with painful swelling of the great toe. Okay, serum uric acid is normal. Synovial fluid showed increased WBCs. No history of fever, trauma, dysuria. What is the likely cause? So the patient is an alcoholic male. Okay, so he has come, he's a chronic alcoholic, and he has come with a painful swelling of the great toe. Now, if you stop at this line, alcoholic patient, painful monoarthritis involving the great toe, the first metatarsophalangeal joint, what will you think of? Gout. Okay, let's proceed further and see if it's a gout or not. The next line tells you that the serum uric acid is normal. Okay, serum uric acid is normal. Now, I have already taught you in my lectures, normal serum uric acid during the time of acute episode does not completely rule out a gout, because some patients who are having hyperuricemia, during an acute episode, there might be a decrease in uric acid, and when you check at that time, you might, in some patients, find it to be normal. So it does not totally rule out gout here. Synovial fluid shows increased WBCs. Now that tells you either there is an inflammation or there is an infection. To make a definite comment, is it an inflammation or an infection, I need an exact WBC count in the synovial fluid, but the students have said that such a count was not mentioned. So I can just tell you either there is an inflammation or an infection. And they've said there is no history of any fever, trauma or dysuria. Okay, so no history of fever, trauma, dysuria. So what I want to tell you is the clinical scenario is that of a monoarthritis. And what are the two important differentials of a monoarthritis? One is going to be gouty arthritis, and the other is going to be septic arthritis. Septic arthritis. So in this case, since the patient is not having any fever, it's very unusual for a septic arthritis to present without any foci of infection. Okay, so in the history, there is no foci of infection that is mentioned. So I do not want to think of septic arthritis, and pseudogout and reactive arthritis is also ruled out. Okay, right. So what is a likely diagnosis here? Acute gouty arthritis. So my dear students, just because serum uric acid is normal at the time of an acute episode, it doesn't rule out gout. I have always stressed to you the importance of the MSU or the monosodium urate. They are the ones which are important for the disease. So the MSU crystals may cause the damage, and some patients during the acute episode, uric acid is normal. Usually it is high, some patients normal. Okay, right. Question number 35, which drug reduces the production of uric acid? So allopurinol, colchicine, diclofenac, probenecid, all of them are drugs used in the treatment of gout. Colchicine and diclofenac are mostly used in the treatment of acute gout. Now coming to the other drugs, see, I have shown you this in my lectures as well on the mechanism of action of various drugs in gout. So mainly you have got certain drugs which will inhibit the production of uric acid, and some of them which will normalize the urate excretion or increase the urate excretion, because the uric acid is excreted by the transporter in the proximal convoluted tubule. So to deal with a gout, you can either decrease the production of uric acid or somehow you can increase the uric acid excretion. So patients who are having hyperuricemia, they may either be overproducers. Okay, overproducers matlab, they are having excess uric acid in the body. Okay, or they may be under excretors, which means they are excreting less uric acid, and that's the reason why they are having hyperuricemia. So what are the drugs that are going to inhibit the urate production? They are allopurinol and febuxostat. Whereas the drugs that will increase the excretion, they are probenecid, lesinurad and benzbromaron. And then you have got the pegloticase, which is an urate oxidase, so which will convert urate to allantoin. And there is another recombinant urate oxidase other than pegloticase, okay, which is ras-buricase. Okay, again, similarly to pegloticase will convert urate to allantoin. Okay, so this is how the various drugs will be acting. And for this drug, for this question, decreasing the production, answer is allopurinol. Okay, allopurinol. Question number 36, a patient presented with white fingers. He is working on an industry where he is handling vibrating instruments, paints and thinners. What might be the cause of this? Is it due to vibrating instruments, due to the paint, or due to the wet conditions? This is relatively a new question. Okay, this even I have not taught this in my lectures. It's a relatively new question. For the first time, they're asking this question in NEET-PG as well. So basically, there is a condition that is vibration-induced white finger. Okay, vibration-induced white finger. So what is this? This is a secondary type of Raynaud's phenomenon, which is caused by exposure to hand-arm vibration. And basically what occurs is there is vasoconstriction resulting in blanching, numbness and pain in the fingers due to the exaggerated vasoconstriction. To an extent, the vibration can also cause some endothelial damage and to the vascular endothelium and subsequently a vasoconstriction as well. So it is multifactorial in etiology, the reason leading on to these pathologic changes. Okay. So this is called vibration-induced white finger. So this is due to vibrating instruments. Okay, not due to the paint or any wet conditions. Okay. Another simple question: 30-year-old male complains of low backache, buttock pain, and early morning stiffness for 30 minutes since the last 2 years. His eyes were always red-looking. X-ray of the spine is shown. What is the most likely diagnosis? Is it ankylosing spondylitis, mechanical back pain, spinal tuberculosis, or disc prolapse? So relatively young adult presenting with low backache, buttock pain and early morning stiffness. The age group and the presentation very typical of ankylosing spondylitis. Tell me, why is the patient having this buttock pain? What is the reason for the buttock pain? The reason for the buttock pain is what? Sacroiliitis. Okay. The reason for the buttock pain is the sacroiliitis. Okay, right. And early morning stiffness is also common with ankylosing spondylitis. And his eyes were always red looking. This is due to uveitis. We had a very similar question being asked in the 2021 NEET-PG as well. The X-ray of the spine is the typical bamboo spine appearance. Yes, the typical bamboo spine appearance. Okay. So they're asking what could be the cause: ankylosing spondylitis, mechanical low back pain, spinal TB, disc prolapse. Simple, it is ankylosing spondylitis. Okay, because in the other conditions you are not going to have any associated uveitis commonly, though tuberculosis can cause uveitis, but the other features are not suggestive of tuberculosis. Okay, this buttock pain and all doesn't occur. Early morning stiffness, not common. Okay, right. Moving on to question number 38. Young boy had a swelling of the jaw. The patient had a translocation 814. The bone marrow aspirate is shown. What is the diagnosis? Is it Burkitt's lymphoma, myelodysplastic syndrome, acute myelogenous leukemia, or hairy cell leukemia? So, young boy with a swelling of the jaw. 814 translocation and the biopsy bone marrow aspiration is showing. So you can look at the aspirate and you can see the presence of certain vacuolations inside the cell. Are you able to appreciate the vacuolations inside the cell? Yes. So basically this is a case of Burkitt's lymphoma. Okay, Burkitt's lymphoma. So please understand, look at this screenshot from Harrison. Burkitt's lymphoma contributes to around 30% of the childhood non-Hodgkin's lymphoma. And in the endemic variant, you have got the patient presenting with jaw or facial bone tumors. And what is important finding on biopsy? Basophilic cytoplasm with vacuoles. And there is a significant proliferation rate. And when you get these tingible body macrophages, this can lead on to a typical appearance known as the starry sky appearance. So commonly they have asked this question also. Starry sky appearance is seen in, that is also in case of Burkitt's lymphoma, and the translocation is involving the MYC gene that is located on chromosome 8, and the other chromosomes with which it occurs are one is 14-2 and 22. So you can have an 814 translocation here. The answer is going to be Burkitt's lymphoma. Okay, right. Moving on to question number 39. 70-year-old male has a total leukocyte count of 50,000. Peripheral smear is shown. What is the next step? So WBC count is elevated. Okay. The peripheral smear is again showing an increase in the WBC count and the arrows pointing to smudge cells. Okay, arrows pointing to smudge cells. Okay, and in the exam no arrow was given, but this is just a representative image. Okay, I'm sure you would have loved such arrows in the exam as well to show you what is the finding. So basically, what is the diagnosis here? It is CLL. Okay, CLL is the diagnosis. And for CLL, what is going to be the next investigation? You have got to do a flow cytometry. Okay, and you can see for CLL, this exact line from Harrison also. So when noting an elevated WBC count with a lymphocytic predominance, the next step is to perform a flow cytometry in the peripheral blood. So flow cytometry and subsequently which will reveal the immunophenotype of CLL, which will show the typical B cell markers 19, 20, 22, CD23 and CD5. So these are the markers, and flow cytometry is the next investigation that you have got to do. Okay, right. Moving on to question number 40. Which of the following vitamin deficiencies causes diarrhea, dermatitis, dementia? Can it be anything simple than this? Answer is the niacin deficiency, which leads on to pellagra, which is the characteristic triad of diarrhea, dermatitis and dementia. Another potential question is the pigmentation that can occur in a particular pattern known as Casal's necklace. Okay, Casal's necklace. You can see the pigmentation over this neck area in the form of a necklace. It's also just worth going through this table in Harrison showing the various nutrients and associated deficiency findings. They do ask some questions. I've seen they're asking commonly regarding thiamine, but sometimes about the corneal vascularization in riboflavin deficiency also. It's a previous question. So please go through this table in Harrison on the various vitamin deficiencies and associated features. Okay, right. Question number 41. A resident of Delhi had fever for 5 days and petechiae all over the body. Platelet count is 20,000 per millimeter cube and WBC count is 3,000. PT and APTD of the patient was normal. What is the diagnosis? Okay, so resident of Delhi. Okay, resident of Delhi is having short febrile illness with petechiae, and the blood count is showing a bicytopenia, which means decrease in WBC as well as platelets. Coagulation parameters are within normal limits. So what is the most common condition that is going to produce this? Dengue can produce. Okay, so dengue can produce. If you ask me, sir, why not scrub? Scrub also can produce fever and a thrombocytopenia. See, the point here is scrub, usually if it was the answer, they would have given some point like an SCAR. Okay, so SCAR will tell you that, okay, this might be a case of scrub, but nothing like that was mentioned. No other feature suggestive of a malaria or a typhoid also. So the best answer here is dengue fever. Okay, right. HIV patient with a palatal lesion, what is the diagnosis? This is something, I've always stressed in my lectures. The patients with HIV, they are having certain nodular lesions. Okay, so the answer here is Kaposi sarcoma. So patients with HIV, they may have abnormal angiogenesis, okay, due to infection with HHV8, resulting in multiple vascular nodules. You will have a reddish purple nodules. Are you seeing the nodules here? Okay, are you seeing the nodules here? So reddish purple nodules in the skin, mucous membrane and viscera, and this can be seen in any stage of HIV infection. Okay, may be seen at any stage of HIV infection. So it is Kaposi sarcoma, the answer here. Okay, it's not a basal cell carcinoma or a melanoma. Question number 43. Asthmatic patient on inhaler develops oral white patches. What is the drug of choice? Is it clotrimazole, griseofulvin, flucytosine, terbinafine? So patients who are taking these inhalers, mostly with steroids, they are prone to develop candidiasis. So the patient has got a candidiasis here, and what is going to be the drug of choice? Clotrimazole. Okay, right. Next question, HRP2 antigen is done for? Well, it's again a simple question. This is Plasmodium falciparum. So this is sometimes discussed with microbiology part as well. HRP stands for histidine-rich protein. Okay, histidine-rich protein. Histidine-rich protein. So if you look at this table in Harrison on the methods for diagnosis of malaria, okay, on the methods for diagnosis of malaria. So in addition to the thick blood film, thin blood film, you have got the a dipstick test for HRP2, and you can see that this is going to detect only Plasmodium falciparum. Only Plasmodium falciparum. And you've got other tests like the dipstick test and the microtubule concentration methods with acridine orange staining. Okay, so the answer here is Plasmodium falciparum. Okay, right. Question number 45. A patient presented with symptoms suggestive of tuberculosis. The sputum smear was negative for Mycobacterium tuberculosis. Chest X-ray findings are suggestive of TB. What should be the next step according to the NTEP, National Tuberculosis Elimination Program? So, see, if it is just a direct question, patient with tuberculosis, symptoms suggestive of tuberculosis, you're having some X-ray findings suggestive of TB, but sputum smear is negative. What is the next step? Ideally, you have got to do the CB-NAT, correct? That should be the answer. But here, they are asking what is the next step according to NTEP. So NTEP, in such a scenario, when the sputum smear is negative, but the X-ray findings are suggestive, what they suggest is first you repeat the sputum sample. So in this case, since they have specifically asked what is the next step, the answer is repeat the sputum sample. Obviously, after that, the next step is going to be CB-NAT. But since this is specifically asking regarding the program, that is why the best answer is this one. Obviously, some of you may have a debate, so why not CB-NAT? But again, from the recall I got from the students, they specifically asked according to the NTEP. Okay, right. You can go through the guidelines as well. So question number 46, a 10-year-old child presented with fever, rashes and Koplik spots on the buccal mucosa. What is the diagnosis? Rubella, measles, mumps and chickenpox. Again, straightforward case. It's a case of measles. Okay, fever, rash and Koplik spots. Koplik spots are associated with measles. 47th question, a 60-year-old laborer collapsed in the summer heat. What is least likely to occur? So what is the diagnosis here? This is a scenario of a heat stroke. So what is least likely to occur? Red and hot? Yeah, the patient can have such sort of an appearance. Hypotension possible, tachycardia possible, but usually you will not be seeing sweating. Okay, sweating is not a feature of the classic heat stroke. So in Harrison also they have mentioned about the manifestations of the heat stroke. The classical heat stroke is the one that occurs in an elderly patient who is already having certain predisposing factors. So in that patient, usually it is anhydrosis. However, you may have diaphoresis in the exertional heat stroke that is seen in younger patients. But since here they have asked about a 60-year-old laborer, most likely it is going to be a classical heat stroke. Answer is going to be sweating. Sweating will not be present in these patients. Okay, right. Coming to question number 48, a farmer is brought to the emergency department with history of organophosphate poisoning. He is being managed with atropine and pralidoxime, and after some time he developed fever. What is the likely cause? Is it side effect of pralidoxime or atropine overdose, symptoms of organophosphorus poisoning, or is it aspiration pneumonia? So see, if you look here, in a patient who is having organophosphorus poisoning, and they have mentioned that atropine and pralidoxime was given, the patient is developing fever. Okay, so there are actually two possibilities. One is due to the atropine per se. You may develop this so-called atropine fever, okay, as a result of administration of atropine. That is due to atropine overdose. You may get pyrexia. You can also even have an aspiration pneumonia. Patients with organophosphorus poisoning, they can have aspiration pneumonia. So one of the option here is atropine overdose, option B, and the other option is aspiration pneumonia. Anyway, it's not a side effect of pralidoxime. I can rule it out. It's not a symptom of organophosphorus poisoning. Okay, so what is it between these two? See, I'll pick the answer as atropine overdose because in the question, there is no feature suggestive of an aspiration. They have not given any auscultatory feature that there are crepitations, nothing like that mentioned. In that case, my best answer here will be atropine overdose. Okay, right. So I hope that is also clear for you. So with that, we are coming to a close on the discussion of the recall questions of NEET PG 2023. So these are the questions which I have collected from the recall of various students. Okay, so I've tried to arrange this with the options that I got from the students to give you a fair enough idea so that your preparation for further exams will get a good direction. I again tell you that, see, the exact same questions may not be repeated, but you have to watch these videos to understand from which all topics the questions are being asked, so that you can prepare accordingly. Okay, I know that this is an important topic. Potentially, I'll get a question from this. I should learn this. So do not miss out on these high-yield topics. Just go through them again and again and keep studying well. All the best.